Dr. Ankur.
Good evening, Somsekhar bhai.
Good evening, Bhavana ma'am.
Yeah, good evening. Hello, Somsekhar bhai. Hi.
Nice seeing you, huh?
Thank you so much.
We couldn't meet, but at least we met online.
Yeah. We met online.
Yeah,
So
good.
how things are going on?
Yeah, fine. Little hectic and busy, as you know, everywhere it is same.
Same.
Good, nice, fantastic.
Thank you for accepting as a commenter.
I mean, my pleasure, my pleasure.
Nobody can be as good as expert commenter like you.
My pleasure.
Yeah.
I think 8:30 everybody will log in, I think, no?
Yeah, at 30 everybody will log in. Yes.
Nice. So how are things in Ahmedabad? Fine?
Yeah, things are getting into the track. I think there are few new cases by now.
Okay.
After this, I think since last 15 days, Mumbai has got a few COVID cases. So now it is also there in Ahmedabad, but not too much as it is in Maharashtra.
Good. Very nice.
Still, things are under control. And we are doing all routine works.
Good. Very nice. Super. Good then. I'm here logged in. When everybody starts, I will unmute myself. I'll be there. Okay. I'll just mute.
No issue.
Okay. Bye.
Okay. Bye.
Very good. Bhavana ma'am, good evening. Albert sir, welcome.
Hi, Dr. Albert.
Hello, nice to see you.
You need to unmute yourself.
Can you hear me?
Srishti,
Yes,
you
sir,
need
we are
to
able to
unmute
hear you,
yourself.
sir.
Is the sound okay?
Yes, sir.
Ma'am, he's on unmute mode. We are able to hear him.
I think you can hear me now.
Yes, sir, we can hear you.
Hello? Can you hear me, Srishti?
Yes, sir. Yes,
Yes,
ma'am.
ma'am, we
Bhavana
are
ma'am.
able to hear him.
Hello?
Bhavana ma'am, you are not able to hear him.
Yeah, I can be able to hear you.
Dr. Albert, would you like
Yes,
to
ma'am.
check if your screen sharing is working properly or not on your end for your
Yes,
PPTs?
good idea.
Yeah. I'll stop sharing.
Ah, perfect.
Srishti, you need to stop sharing. Yes.
We'll start exactly at 8:30 p.m.
Yes, that's fine.
Hmm.
Um, hold on. Oops. Zoom, share screen. Yeah, here it is.
Yes. Yeah, we can see your screen, sir.
You can see it, huh?
Yes, we can see it. Sir.
Perfectly fine, sir.
Perfectly fine, sir.
Okay.
Yes, sir. It's clear.
Yes, sir. Sir, we have got our one of the expert commentaries already logged in, Dr. Somsekhar, sir.
Yeah. Shall I stop sharing?
No, you keep it like this, sir. We'll just
Keep
start
it like
exactly.
this?
Yeah, you just keep it like this. We'll start exactly at 8:30 p.m. You have to make it large. You have to make it the full screen when as soon as you start the lecture.
But this is large, I think.
Okay. That's okay.
Or do I need to do anything else?
Nothing, I think.
No, sir. It's fine.
Is it okay?
Yes.
Yes, sir. This is full screen mode.
Yeah.
This is perfectly fine, sir.
Okay. So it's the evening already now.
Yes, sir. In India, it's already.
Uh,
Srushti, meanwhile, can you just check Facebook live streaming is going on smooth? Just check, log in into your Facebook account as your ma'am's friend on Facebook. You will be able to just confirm me.
Let me check
Just
Sure,
check
this.
sir.
that
So
audio
give
video
me
is
two
clear.
minutes. Yes, sir. Give me 2 minutes. I'll do it.
Yeah. Yeah.
Ankur, we have
Bhavana ma'am, as if now, right now we are live. Our testing is clear from my end. We are
let,
just cross checking with Srushti that everything is clear at her end as well.
no, I already have my Facebook open, but I can't see it actually.
Yeah, ma'am. You're able to see it, ma'am?
No, I'm not able to see it. No, I won't be able to. I mean, I'm not being able to see it. Ankur, can you listen? Can you hear me?
Ma'am, just a minute. Srushti, can you just confirm? Because from my end, I'm able to see that I'm live.
No,
Because this
sir.
exactly.
On her page as well as on her personal account, I can't see her Facebook live.
Okay. Uh,
It is just her last post of this webinar.
but I am able to see this. Bhavana Parekh, cancer surgeon, Ahmedabad.
Ankur,
Yes, ma'am.
can you just send a link so we can? I
Yeah,
just
ma'am. I'll do that. I'll do that.
hello.
ಇರು ಮರಿ ಮುಟ್ಟಬಾರ್ದು ನೀನು
Catering to the audience properly.
Ankur, Ankur,
Yes, ma'am.
Ankur, can you, I think it is already. We're about to. Hello.
Ma'am, I'm sending you the link of Facebook.
No issue, but I think we should start around. I think it's 8:30 already.
Srushti and ma'am, both of you have sent the Facebook link. You can just check. We have still 1 minute to go. If in case if it's still not live, I can just retry. It will just take me 60 seconds.
Okay. You send me link.
Yeah, I'll do it in chat box as well. I have done sharing of the link in the chat box as well. So far we have 66 participants.
No issue, and just send me that by message also, WhatsApp message also.
It's live, right, ma'am?
No, I can't see it, but send me a link on WhatsApp.
Ankur, sir, to me it shows the content is not available.
Okay.
It is same,
I'll just.
it is same here.
On the link also, it is the same issue.
Yeah, it is same at my end also.
Acha, I'll just give me a minute again.
সন্ধ্যায় খাইছি
Is it regular?
ফাইসা জুমে করতেছিল না হ্যাঁ।
Rampur?
আরে পেঁচাও ব্যাপারটা আমি একটু বলি
Dr. Ankur?
Yeah, ma'am. Just a minute more. Just a minute more. Yeah, we are live again. Ma'am, good to go. We are live again.
Okay, no issue. Shall we start?
Yes, ma'am.
Okay, just send a link on my WhatsApp. So if anyone asks,
Yeah. I'm putting in chat box once again.
okay, no, just send it by WhatsApp also.
Ma'am, also in case anyone missed it, we are recording the session. So that link can also be shared.
No, this is only for somebody who cannot be able to join by Zoom. So this is an additional thing for the other people.
Sure,
We have,
ma'am.
I think, our all three expert commenter already logged in. I can see many of the senior consultant also. Just start with introduction about Dr. Albert Walthius. Thank you very much, sir, for accepting this invitation, and you actually don't require any introduction. Dr. Albert M. Walthius, he graduated from medical school in 2002, KU Leuven University, which is one of the best university in Belgium. He became a general surgeon in 2008. His main passion and interest in colorectal surgery, abdominal surgery, minimal invasive colorectal surgery, transinguinal surgeries, redo surgery, debulking, and HIPEC. He is a fellow of American College of Surgeons, fellow of American Society of Colorectal Surgeons, and he passed his European Board of Surgical qualification exam also for coloproctology and surgical oncology. And he is secretary of Journal of Belgium Group of Endoscopic Surgery. He's regular reviewer of many surgical journals and associate editor of European Journal of Surgical Oncology, and he co-authored around 80 peer-reviewed publications. So I hand over to Dr. Albert, and he will start his lecture soon. So over to you, Dr. Albert.
Thank you very much,
Thank you, sir.
ma'am. If there is a problem with the screen or with the sound, please tell me up front, then we can try to solve it. But if I don't hear anything, I will just proceed with my presentation. It's a great honor to be with you today. Although there is a time difference, it's a nice opportunity to share some ideas. And Dr. Parikh has asked me to speak to you about neoadjuvant chemoradiotherapy for rectal cancer and bring into the discussion surgery versus watch and wait approaches. And I will focus a little bit on watch and wait, but I will also show you what the drawbacks and what the pitfalls are when you want to embark on a watch and wait protocol. So I have no disclosures. If you look at the actual treatment in rectal cancer, you see on the left hand of the screen that for early rectal cancer, T1, sometimes T2, you can do local excisional procedures, TEM, transanal excision, TAMIS. For more advanced rectal cancer, the mainstream is still radical surgery by means of a total mesorectal excision, a proctectomy, and you can do it robotically, laparoscopically, open or transanally. But then if you combine it with neoadjuvant chemoradiotherapy, you see on the right hand of the screen that some patients will end up in an organ preservation wait and see protocol. Well, let's talk about TME first. And TME is really popularized, as we all know, by Bill Hield, total mesorectal excision, embryological planes, meticulous dissection, and it really has shown that TME optimizes local control rates. Local recurrence rates really drop down to around 5% if you perform a TME in the proper way. But it has also some mortality, some morbidity attached to it. It's not a completely innocent procedure. And as we all know, there is sometimes need for temporary stomas. Also, permanent stomas can be into the discussion. And on the long run, we have some urogenital dysfunction, bowel dysfunction, and of course, this has an impact on quality of life. If we then look at the TME specimen after chemoradiotherapy, we noticed that in around 15 to 20% of the patients, of the cases, there was no residual tumor left. So you treat a patient with chemoradiotherapy, you do a TME, and when you have the specimen, you don't see residual tumor. And then you say, well, this is maybe a regret. Why did we do this operation when there was no cancer there? On the other hand, we know that if we have a patient with a complete pathological response, YPT0N0, this patient will have a very good prognosis. As you can see here on the blue line, disease-free survival is significantly better in responding patients compared to non-responding patients. But then really that is changing the paradigm because surgery is the cornerstone in cure for rectal cancer. And a non-curable local situation is unacceptable. And this is what we sometimes saw. We did a nice TME, a perfect TME, but in the end, there was nothing but a scar in the specimen. There was no tumor left on pathological examination, making us think of why we did this a big operation with need for temporary stomas and so on. We know that PCR, complete pathological response, as I told you, has the best prognosis, but how do we get there is the question. Another question, and that is the question that we try to answer today, is can we change our strategy after chemoradiotherapy? So you have on the left side a patient with a big bulky tumor very close to the anal sphincter who is in need for an abdominal perineal rectum amputation for an APR, who then undergoes neoadjuvant chemoradiotherapy, and the tumor has almost gone. So that makes you think of, can we change the strategy by adapting our surgery, performing sphincter saving surgery, performing local excision, or even watch and wait on this patient doing nothing at all but close surveillance. If we ask patients and if we look at patients' expectations, we see in this very nice study from the USA that on the left hand, purple bars is what is most important to patients, and patients don't want to have a permanent stoma. You see here that the majority of patients answered that they want to avoid a permanent stoma. And then on the second place, it's being cured of cancer, of course. But a stoma is a very important aspect in patients' expectations. And that is really why this lady from Brazil undertook the watch and wait strategy approach. Angelita Habergamma was really a forerunner in selecting patients who had neoadjuvant chemoradiation in distal rectal cancer and who had a complete response at 8 to 10 weeks and then a sustained clinical response after 1 year. And she really observed that these patients could be entered into a watch and wait protocol, avoiding a stoma, avoiding the major morbidity of radical surgery. And she could show that outcome with overall survival, disease-free survival, was good in well-selected patients who had a sustained response at 1 year. What is a complete clinical response? And you can see that here. There is a nice definition when you look at it with the endoscope. You should not see any tumor, of course. You see the whitening of the mucosa. You see the association of the small blood vessels, the telangiectasia, what you can see here in the picture. You see the subtle loss of pliability and light stiffness. And of course, that the tumor is completely absent. So this is, for me, a complete clinical response after neoadjuvant therapy. How do we get there? You have to discriminate between small and large tumors. For small tumors, you can do an intentional organ preservation strategy. You give chemoradiotherapy with the purpose of obtaining a complete response, with the purpose of avoiding major surgery. And in smaller tumors, you have a higher success rate. You have more than 50% of tumors who will completely respond on neoadjuvant therapy. On the other hand, you have that incidental finding of a complete response when you irradiate a large tumor. And this is the category of patients that we normally look at. We treat those patients with neoadjuvant therapy, locally advanced rectal cancers, T3 plus, N plus, and one disease. We give them chemoradiotherapy, and we see that in 10, 15, sometimes 20% of the cases, we end up with a complete response, and we can enter these patients in organ preservation strategies. And why is there a difference? Because the tumor volume will dictate on how long it takes to get a complete response. Radiation-induced necrosis, the apoptosis, is really a time-dependent phenomenon. So the larger the tumor you start with, the longer it takes to get a complete response. And that has also been shown in two very nice reviews, is that looking at the percentage of patients with a complete pathological response, you can see that here on the y-axis, PCR rate up to 15%, and it takes a little bit to get there. It takes on average 11 to 12 weeks to get to the plateau phase. So it takes some time to get to the complete pathological response. And that has also changed in our practice, because we used to assess patients at 6 weeks. We now change to do the assessment at 12 weeks and then make the decision whether we go for radical surgery or we go for a watch and wait approach. What do you do if there is a near complete response? There is a good response, but it's not complete yet. Then the group of Gerard Bates from Amsterdam has shown that you have to wait a little bit longer. Remembering the time-dependent phenomenon, you wait a little bit longer, and 90% of those near complete responding patients will have a complete clinical response at 12 weeks, and overall a local recurrence-free survival is not significantly different in those group of patients. How do we assess response? It is also a very important question, because you have to be sure that the patient can be watched on, that this patient will not have a tumor left. And we do a combination of 3 investigations, examinations. We do, of course, a digital rectal examination, and that is only possible for patients with distal tumors, distal rectal tumors, of course, combined with an in the office flexible endoscopy, as you can see here, flexible endoscope to rule out that there is any tumor left. And then we do a diffusion weighted MRI, which has been seen by a dedicated radiologist. And with those 3 investigations, it has been shown that the combination performs best. So the combination of a clinical assessment combined with MRI has an accuracy of almost 100% to predict response in a rectal cancer treatment. So we always rely on that 3 investigations. Apart from that, and that is sometimes the difficulty, is that a complete clinical response does not always equal a complete pathological response. And I have prepared 2 images, 2 examples here, where you can see the endoscopy and the MRI on the top end picture showing a complete clinical response. For us, this is a complete response. There is no tumor left, and the MRI was perfectly normal. And at 12 weeks, we did a TME, a total mesorectal excision radical surgery was performed, and we still found a small remaining tumor in the specimen. On the other hand, we had a positive MRI here saying, our radiologist saying that there was active tumor cells left with an YCT2N0. We did a TME at 12 weeks, and we did not find a tumor in the specimen. So there was no tumor in the specimen left. So that brings us to the actual problems, the actual questions of a watch and wait approach because the accuracy of restaging modalities is still not 100%. What do we think of the role of biopsy and local excision to document whether there is tumor left? What is the interval necessary on when to assess tumor response, and how would you organize your follow-up? So let's talk a little bit on biopsies, because if you perform a biopsy of a scar, the problem with that is that the biopsy has a very low negative predictive value, leading to a very low accuracy of only 71%. So if the biopsy is negative, it doesn't tell you anything. So that is the reason why we don't perform any biopsies in during our flexible endoscopy. So you can say, well, don't perform a biopsy, perform a big biopsy. Why don't you perform a full thickness local excision of the scar after chemoradiotherapy? The problem with that is, and it has been shown in some reports, and there is also a randomized trial from France um, um, comparing local excision with TME, is that patients have significant more pain after chemoradiotherapy, significant more readmissions, significant more wound infections, intrarectal abscesses, and oncological outcome comparing local excision versus TME is the same in this randomized controlled CRECA2 trial. So we don't perform local excision after chemoradiotherapy because we are afraid of that wound infections leading to more pain in the patient. The problem is, however, if you have a complete clinical response, your patient is fine. But if you have a local regrowth, then you might have a problem. And then the question is, do we harm our patients by waiting? And what is the oncological outcome in this subset of patients who develop a local regrowth? And you can see that local regrowth rate is documented to be around 20% in these reports from Brazil combined with the UK. 96% of the patients have a local regrowth within the 3 years of follow-up. So from the end of chemoradiotherapy, 3 years later, almost all patients have the local regrowth in that period. Salvage surgery is possible, and that overall sorry, can you hear me?
We can hear you. We can hear.
Okay. Shall I just proceed?
Yeah, please proceed.
So this is the so this is the problem with local regrowth. It's a kind of biological marker of patients who have a bad oncological prognosis. Because if you look at patients who develop a local regrowth versus patients who still have a complete response, and you have two papers showing that, is that in the group of patients who develop a local regrowth, there are more patients with distant metastases. And you see here that there is a significant higher rate of distant metastases when patients develop a local regrowth, meaning that they have a tumor with bad oncological biology. 36% of the patients in the watch and wait group who develop a local regrowth also develop distant metastatic disease. So that is a bad sign, and you always have to look for metastatic disease in that patient who develop a local regrowth. This is a a review with a regrowth rate of 16%. And this is a kind of plea for surgery because in the watch and wait group with a complete response versus patients who underwent radical surgery with a complete pathological response, they had a better disease-free survival after surgery. So the patients who were operated on had a better disease-free survival in a comparison to the patients who had a watch and wait approach. The risk of local regrowth, again, pooled data set, it's around 21% at 2 years. So 20% failure of a watch and wait approach, and with an increasing C stage, CT stage, tumor stage, there is an increased risk, of course, for developing a local regrowth, and that is obvious. Another quite interesting concept is conditional survival, meaning that the longer you have your complete clinical response, so the longer you are away from the end of your radio and chemotherapy, the better your survival and the better your prognosis is. So there is a recurrence risk over time, meaning that if you have passed 2 years of follow-up and you still have a complete response, you have a better recurrence-free survival because you have a better tumor biology. So this is the concept of conditional survival, and it is important to tell your patients that follow-up is important, but that also longer follow-up will lead to better outcome. The longer you have without tumor, the better your outcome is. Can we salvage those local regrowth patients? So this is a patient who had neoadjuvant therapy, who entered the watch and wait protocol, but then most of them within 2 to 3 years of follow-up develop a local regrowth. You can see the incidence here of 31% early and late regrowth combined. Salvage is possible in more than 90% of the patients. So that patient then still needs to undergo a total mesorectal excision, can undergo a TME with disease control of 94%. But the question is, of course, could all of these patients have been saved by upfront TME? And that is a question that is very difficult to answer because there is no randomized trial who could possibly answer that question. What is the result of salvage surgery? You see that pooled 2-year local regrowth, again, 16%, salvage therapy in 95% of the patients, and there is no significant differences of non-regrowth cancer recurrence or overall survival. So outcome is the same in this cohort. Again, a pooled local regrowth analysis of 21%, salvage surgery in 93% of the patients, and no difference in survival. This is the overall paper, a systematic review on salvages for local regrowth patients, a systematic review of a couple of years ago, including 9 studies. Salvage was a little bit less possible, below 90% in 84% of the patients. Salvage was still possible, so the majority could be salvaged, but there is insufficient evidence on oncological safety because we also have to bear in mind that these patients are more prone to develop distant metastatic disease. Another tricky thing of the watch and wait approach is the positive lymph node in the mesorectum. So does YPN plus matter? And this is data from the States analyzing a huge amount of patients who underwent chemoradiotherapy for locally advanced rectal cancer, and in 30% of the patients there was residual nodal disease. And of course this had an impact on survival. So you should bear in mind that also tumors that respond on the T stage level very well still have the possibility to have a positive lymph node in their mesorectum. 6% in T0 disease, and it goes up when the T stage is increasing. And that of course has an impact on overall survival. And zero disease is better prognostically than N plus disease. And that is also been shown in this graph, showing the recurrence-free survival is worse in good responding patients with N plus disease. So tumors that on a T stage level respond well, but still remaining lymph node in the mesorectum will have an impact on the prognosis, on the recurrence-free survival later on. What we also have to bear in mind, and I will finish in a minute, is that a watch and wait approach will also affect bowel function. So some patients, although they haven't had an operation, they will develop some kind of low anterior section syndrome symptoms. So chemoradiotherapy will also impact bowel function. So what should we do? What is the overall thinking? What is the overall attitude of surgeons regarding this issue? And this is a very nice survey from Brazil, from Sao Paulo, showing that over time, and you see that they've done the investigation in 2007, the blue bars, and 2013, so 5 years later, in 2013, you see that a significant number of surgeons have changed their mind, have changed their opinion of a watch and wait approach. So one of the options of a complete clinical response is non-operative management with close follow-up. And you see that there is a significant higher number of surgeons who is willing to treat patients with a watch and wait approach, but it's still only 20% of the cohort that underwent this investigational survey. So here in summary, you can see the limitations of a watch and wait approach. There is no, as I showed you, there is no exact correlation between complete clinical response and complete pathological response, with a local regrowth rate of around 20%, making you questions about fibrosis versus residual tumor cells. Salvage surgery is feasible and safe, but we have to bear in mind that there is a higher APR rate and a higher local recurrence rate. And to date, there is no prospective evidence, no wider clinical applicability, because there is no standardization in patient selection, neoadjuvant therapy regimen, diagnostic technique for response assessment, remember the MRI accuracy, definition of local regrowth and local recurrences, and proposal of follow-up strategies. So in conclusion, and it's open for discussion, of course, I dare to say that TME, the total mesorectal excision, remains the gold standard to cure our patients, that patient selection for a watch and wait approach is key, that assessment of complete clinical response is unreliable at the moment, that local regrowth has worse outcome, and when in doubt, it has to come out. Thank you very much for your attention, and I'm happy to ask and discuss any questions.
Thank you, Dr. Albert, for such a nice presentation. And I request, there are a few questions in the chat box that we will take it later. And I asked Dr. Somshakar Bhai for giving an expert comment about surgical aspect.
Hi, Professor Albert. Nice seeing you again.
Nice to see you.
We would wish to welcome you back in India again. I wish you can come when the COVID settles down, and it would be nice to have one-to-one discussion.
We'll be happy.
That's a fantastic talk you gave. It's an excellent talk, and then the conclusion was a little disappointing. I thought, like, you would be little in favor. I understand because there are no randomized controlled trial. The conclusions has to be what you put it actually. The whole issue when we analyze, one is, number one, there are no randomized controlled trials, even though about 3 or 4 of them are going on. And the very fact that pathological CR can truly be assessed only by pathological examination.
Mm-hmm.
Clinical complete response doesn't mean what it is. And Haber Gamma trial, unfortunately, is not sort of replicated by others. I would like to also quote for the benefit of the audience. A similar small volume analysis from Emory and Sloan Kettering found that 75% of complete clinical response by MRI, scopy, biopsy, and imaging actually had a tumor when they operated. And Nakagawa et al. Trial showed that in spite of complete clinical response in the observation arm, 80% had recurrence. And we actually think if the patient is on regular follow-up, we can actually pick up the recurrence and we can salvage them. But most of us know that when there is a radiation-induced ulcer, which we keep following, in the Nakagawa trial, 80% recurrence, only 40% could be salvaged by a radical surgery, which means a potentially curable surgery. Sometimes, even though patient is on regular follow-up, they may not end up with an abdominoperineal resection. Sometimes it could very well be some form of partial pelvic exentration.
Mm-hmm.
So this is one of the issue we have. But I just wanted your opinion. What is your opinion on FOWARC trial, FOWARC, where we all know that once we move to TNT, surgery is getting delayed as late as 12, and sometimes you have an aggressive medical oncologist who sort of pushes it to 13, 14, and we know the moment we cross 12 weeks of golden period, the surgical complication little bit go on a higher end. More so the sexual and urinary nerve function because of the radiation. So this part was explored in FOWARC trial, where neoadjuvant induction chemo followed by radiation and surgery still in about under 12 weeks. So do you think this strategy may sort of work as help? What is your thought on this?
Yeah, that is a very good question and a very good point, because we also have a quite aggressive radiation oncologist and oncologist. The the problem is that with when you look at the study from the Netherlands, the Rapido data, it's a combination of a short course radiotherapy with intense chemotherapy. You really increase the interval, or you really increase the period that patients undergo neoadjuvant therapy before they come to the surgeon. And because of the good data from the Rapido trial, we also changed our strategy a little bit. So we also embarked on this TNT approach. And what we will probably see is that we will have probably more patients who will respond better, but it will come at a cost, as you tell us. I mean, there is no doubt that these treatments are not completely unharmful. So I think we really should wait for long-term outcome data regarding function, but also regarding difficulty of surgery, more radiation-induced necrosis, more leaks probably, more needs for stomas. It's still an open discussion, but we are well aware that increasing the interval might also cause surgery to be more difficult.
Absolutely, and you enumerated in your slides and talk very well that YPT0 doesn't actually mean N0 pathological. So you may have a T0 complete response at the primary site, but it is extremely difficult to evaluate the lymph node. And as per your talk, even when we have YPT0, 12% is N plus, and that is one of the cause of actually the recurrence. So what is your opinion on OPRA trial, OPRA? So where you just go and do a local excision because they're all low tumor to analyze who are actually truly pathological CR. So do you think that could still be a middle path? Like, we have observation arm and an aggressive radical surgery arm. We know that both of them are very thin, narrow line. Do you think that somewhere follow the OPRA trial, like you complete and then you have a clinical complete response and do a local excision? Those strata, maybe if you observe, do you think we could have a better outcome?
Yeah, I think so, but it really depends on where the tumor is. I mean, if you have an anteriorly located tumor or scar, and if you do a local excision in that area, it will be very, very difficult to do a nice TME afterwards. So location of the scar of the tumor is very important, I think. And it's also very important that you have a good discussion with the patient, because when you do a local excision, the chance that if the patient needs additional surgery, the chance that he needs an APR afterwards is higher than you do a radical surgery upfront. So I'm a little bit unease with local excisional procedures, but I'm not radically against it, but you should have a very balanced discussion with your patient.
Unless like you do a transanal sort of TEMS-like excision, but unless it's a posterior based tumor, it's extremely difficult.
Sure.
Before I hand over to Bhavana for other questions, I have to ask you, I will just analyze in nutshell the way we debate the Rapido trial, and I want you to give an expert opinion. I will put it this way. The Rapido trial, the trial arm had doubling of PCR. 14% went on to 28%. Yeah. Yet local regional recurrence in control arm, in the experimental arm is more. Yet overall survival across the group is same. Very surprising. You doubled PCR, still your local recurrence in the TNT arm, instead of being low, it is more, and overall survival is not. Don't you think for a good statistician and a science student, there is something to worry? What's happening here? We doubled the PCR, yet local regional recurrence is little more, and overall survival across the group has not changed. What do you think would have led it to this?
Yeah, that's strange. I don't have an explanation for that.
Yeah. So in your practice, which patients you are totally switched over to TNT? Because if you see the data, N2 plus and low rectal tumors below the pelvic reflection, actually short numbers, small numbers in the Rapido trial. Rectosigmoid, upper rectum, mid rectum, yes. So little bit people are apprehensive. If you have a I request everybody to mute themselves. So, in the low tumors, low rectal tumors and N plus, Yes. So the low rectal tumors and high nodal burden below the pelvic peritoneal reflection, are you comfortable putting them to TNT based on the current data?
Well, that is what we do in current practice with the patients with low locally advanced rectal tumors below the reflection with N plus disease. We treat them more aggressively with chemotherapy with short course radiation. That is what we do. But I agree with you that we're still puzzled a little bit with the data as well. But that is what we do nowadays.
Okay. The
Because we believe that patients are in need for more intense chemotherapy sooner. And with the long course chemoradiotherapy, they just get 5-FU and a long period. But patients with N plus disease, they need chemotherapy at a more intensifying base, we believe.
Okay, can I know, do you use a classical rapido, like you start with 5 fractions short course, and then you follow it up with chemo? So the surgery invariably is beyond 12 weeks.
Yeah, we do a Leuven modified rapido.
that's what we do. We start with 2 Folfox or Kepox, and then we do 5 fractions, then we do 4 more. So still I end up surgery before 12. That is what we have been started following now.
Yeah, I agree on that scheme.
Okay, the only thing as a surgeon, when I sit in a multidisciplinary tumor board, I worry as a surgeon. We have started seeing very intense 17 to 20% diarrhea, and this is not the normal diarrhea. It is really troublemaking to patients, extremely. And second thing is, we know that in the original trial, what worries me most is like most of the rectal cancer now are minimal access. In a TNT arm, there is a more conversion to open. It's reported, and that's something worrying. We know in rectal cancer, you start with a minimal access, you end up opening. They have a different outcome than a patient who starts with open surgery and ends with open, or minimal access to minimal access. So I'm okay that we have an increased blood loss, but conversion chances in TNT arm, as per the randomized control trial, is little more. Is that worrisome for a surgeon? Do you think should we worry how to correct that?
Yeah, it's probably not the power of the study to really show a significant difference, but of course it's worrisome because we know that converted patients do worse. So I absolutely try to avoid conversion. And that is also why I'm a great proponent of the transanal approach, because with that approach, you can really let your patient benefit from minimally invasive surgery. Yeah, you see a little bit more conversion to open, which is not a good thing, I think.
Okay, the last question. Taking clue from the prospect trial, do you think a day will come, we just give intense chemo, no radiation, and go ahead with surgery? What do you think? Where do you think is the trigger trial and prospect trial heading to in this total neoadjuvant treatment arm?
Yeah, well, that is also for colonic tumors, the Foxtrot trial. We will probably in future, when we have more powerful immunotherapy and more powerful chemotherapy, we will probably not operating on patients anymore, which is bad for us, of course.
Thank you very much. That was lovely taking from you. Over to Bhavana.
You're welcome.
I hand over to Dr. Vinita Goel. Can you please unmute Dr. Vinita, madam? She has I think the list of comments she said to me. So, madam, you can share your PPT also. Srishti, can madam share her PPT?
Yeah.
Yes, ma'am, that is possible. There is a share screen button down at the taskbar. Just click on that and keep that in presentation mode. You'll be able to do it.
Srishti, we have got many senior consultant over here, so we'll give a chance to speak everyone about this particular topic
Sure.
after the medical
Sure.
policy and madam's comments are over.
So hello everyone and hi Dr. Albert. Thank you for a wonderful presentation. I'm Dr. Vinita. I'm a radiation oncologist. So I completely agree with your presentation and I think you covered everything very well. I have two questions for you. My first question is that would you offer this watch and wait protocol to somebody who's having mucinous carcinoma or signet ring carcinoma? That's my first question.
Yeah, that is very difficult because that's a very good point. What you sometimes see on the MRI is that the tumor disappears, but that the mucinous component is still in the wall or in the mesorectum. And then sometimes the radiologist doesn't know whether this is active tumor or just acellular mucus. So I would be inclined to not offer watch and wait approach to these type of patients because there is too much doubt on MRI, and most of the times we end up operating these patients.
My point behind asking this question was that, apart from difficulty in interpreting MRI, these tumors are also biologically more aggressive for a local recurrence as well as distant failure.
Yeah, that is definitely the point. We have many mucinous tumors also from other origins, colonic, appendicular, rectal, and they definitely have a worse prognosis than other tumors. Yeah, it's sometimes very difficult to treat.
So my next question is that you showed that patients who get local regrowth after a watch and wait protocol also have a higher incidence of distant failure. So when you're doing salvage surgery for some of these patients, do you also routinely offer them adjuvant chemotherapy?
Yeah, that was, sorry, I saw that in the chat as well. And I cannot type very fast, but it's a good question. Yes, we definitely give them adjuvant therapy as well. Yeah, yeah. So it's definitely a candidate for adjuvant therapy. Yeah, we do 6 cycles of Volvox.
Last comment and a question. Surgeons are very strong-headed. They believe that cancers can be cured only when they can be removed. So do you think that good majority of surgeons will turn around and, accept this watch and wait protocol?
Yes, I'm sure. I'm sure, because we also know that that surgery can be really mutilating, and we also have to deal with the functional complications with sexual dysfunction, urogenital dysfunction. So if we can avoid surgery, then I think surgeons will be, well, they will be inclined to do that. But I think, and that is an important point, I think that we as surgeons should follow these patients up, because we have to decide when to operate on this patient. So I think that follow-up by surgeons, discussing it at an MDT, is very important.
So, Dr. Bhavana, give me a few more minutes. I'll just present
Please share.
on this. I have only a couple of slides to show. So I think rectal cancer management has become much more complex over the last few decades because of use of neoadjuvant therapies have introduced a new variable, and that variable is called as tumor response. I want to emphasize that this protocol is not wait and watch. It is watch and wait, which is akin to response adapted, tailored to subjects. I believe in watch and wait. I believe in watch and wait, although there is no level 1 evidence, it is still analysis of cases. If we have randomized, I'm sure we have in the future, we would be able to identify even analysis of
Madam, we are not been able to see your.
large number of patients. It's a
Dr. Vinita, ma'am.
Madam, the audio is not good and the slides are also not seen. There is only single slide which is seen.
Are you seeing it now?
Yeah. Just share your screen. Yes. Now I'll be able to see it.
You're not able to see it?
Yes, madam. You now have to enlarge it and make it a full screen.
Bhavana, is this good now, Bhavana?
Madam, your audio is not good. Your audio is not good. Probably your internet connection is not well actually.
Dr. Vinda ma'am, if you can share the slide, I can share it on the screen because usually when video and audio both are on in a low
Madam, you switch off
connectivity,
your
there are
video.
issues.
Madam, you switch off your video so your audio will be clear.
Okay.
Yeah.
Yeah, I am doing that, ma'am.
Okay.
Yeah. Ma'am, you need
Nita,
to
ma'am, I've
share the
switched off
slide
your
again.
video. This will increase your bandwidth. Yeah.
Bhavna, I've already shared my screen. Are you able to see it?
No, we can't. I mean, I'm not been able to see it.
No.
Share it again.
Let's ask the medical oncologist to present his view.
Yeah, okay, I'll do that. We have Dr. Ashish Joshi with us, who is a medical oncologist, and he's going to give an expert comment about chemotherapy aspect. So, Ashish, are you there?
Yes. Good evening, everyone.
Yes, good evening.
At the outset, thanks, Dr. Bhavana, for giving this opportunity. And it was indeed a wonderful talk by Dr. Albert. I think we're looking at CA rectum, something like CA cervix, where definitive CTRT maybe is that going to be the ultimate goal. So I have a couple of questions to Dr. Albert here. We see a lot of young patients with rectal cancer here in India, and that's where I believe that this particular concept is quite provocative, because for them the quality of life, sexual dysfunction, and so on and so forth are very, very important. So from the medical oncology perspective, do you think there is any role of augmenting the chemotherapy approaches along with the radiation? You could add probably, folfoxyri plus for a young fit patient. Would you do that in your clinical practice there?
Yes, we would definitely do that. In young patients, we really, so to say, hit them hard. I mean, with really intensifying chemotherapy, also extending chemotherapy in the interval will also increase the response. There's the observational prospective study by Garcia Aguilar from the Memorial has shown that if you really intensify chemotherapy and extend the chemotherapy in the interval, then you can increase response rate to even 44%. And especially in young patients, in young fit patients, we sometimes give them FOLFIRINOX. Yes.
Because typically we've seen that probably infusional 5-FU with radiation is not so commonly used in Indian setting. I think it's the capecitabine which probably rules the roost. But we've often seen occasionally some of the patients not tolerating capecitabine that well, and then we have to reduce the dose, or dose density or intensity goes down, and probably that's why we do not see as good a pathological or a clinical response rates to neoadjuvant treatment as what probably we should have. So probably one thought out here is that we could probably augment and give the optimal chemotherapy regimen, and maybe FOLFOX could be one of the ways for especially young fit patients.
Yeah, I agree.
And also, second important point, would you sort of have some thoughts on, suppose those patients who have got a good clinical response, you're not going to operate these patients, would you want to put them on a capecitabine for a period of 6 months?
Yeah, we don't have experience with that. What we used to do is when patient had a complete pathological response, so who had a TME and then no more tumor in the specimen, we offered them 3 more months of adjuvant chemotherapy because they had a good response. But now, if they have a complete response, complete clinical response, we don't extend the chemotherapy anymore. I don't think there is any evidence to give them capecitabine any longer. At least we don't have any experience with that, to be honest with you.
Yeah, thanks, Dr. Albert. I think it was really wonderful and discussion. And as far as the medical oncology and chemotherapy is concerned, I think these are the 2 or 3 very important queries which I'd had. And I can now open this discussion for the forum to take it over. Thank you.
Thank you.
Can we have a madam again? Shushti?
Yes, ma'am.
Yes.
Bhavana, I made my point, so I would request that you give chance to others to ask their question.
Okay, okay. I think Dr. Rudra has a question. Can you please unmute Dr. Rudra Acharya?
Yeah, it was very nice talk with I think all permutations, combinations discussed by Albert. But my question is that extending the TNT protocol from Rapido trial, will it be wise to give some form of chemotherapy for in the waiting period after long course CTRT? Because even after long course, you have to wait till 12 weeks. So there is always a sense of fear of having a systemic failure. So has any experience, or do you think it is a right protocol?
Yes, definitely. This is a very good point. And especially in patients with N1 disease, in the interval, and it has also been shown by the Sao Paulo group and the group from the memorial. We give them 3 cycles of Volvox because your concern is right. I mean, 12 weeks is very long, and you don't want them to escape. So we give them a kind of consolidation chemotherapy, definitely.
Is Dr. Vinita back? Can we ask to Madam Shushti?
Yes, ma'am.
Yeah, ask Dr. Madam. I mean, she is able to share a screen or not. Otherwise, I will take her questions. There's a question from Dr. Sagnik Raya. He asked that in early tumor T1, T2, N0, it is mandatory to do MRI for clinical response assessment. We can unmute Dr. Sagnik Raya also. Dr. Albert?
Good afternoon, Dr. Albert. Good evening, Dr. Albert.
Hello.
Hello.
Hello. Hello.
I don't hear it.
Okay, he asked in the chat box in a T1, T2, N0, is
Yeah.
it mandatory to do MRI for clinical response assessment?
Yes, we definitely need MRI for clinical response assessment. You don't want any surprises in the mesorectum. So yeah, we really rely on MRI. We don't do any endoanal ultrasound because of the investigator dependent accuracy. We really do MRI. And we don't, I see another question here. We don't give adjuvant chemotherapy when patients have a YPT1 and 0. That's the question of Dr. Singh, I think.
Yes. I think he asked, is there any role of PET CT scan in the wait and watch policy?
Yes. So we really do a CT scan also to follow up for distant metastasis, because patients can have a complete response locally and can develop lung metastases. So you have to do CT scan every 6 months, I would say.
Okay. There is a question by Dr. Meena Thakur. Is there if there is still a bulky disease after chemo radiation, what should be your recommendation?
Well, then of course you have to do radical surgery.
Yes, yes, yes.
If there is not a good response, you should. I mean, you will still end up operating on a lot of patients. I mean, not all patients will have a complete response or a near complete response. There are tumors that do not respond to neoadjuvant therapy, and you will still end up operating on those patients.
There is another question by Dr. Bindu Joseph. It is the same question about PET CT scan. What is your opinion, or opinion of the limitation and indication of PET CT scan in wait and watch policy of rectal cancer, locally advanced rectal cancer?
Yeah, that's a bit difficult because it depends on which cutoff value you use. But there is some work showing that if you have a change in SUV max, you can assess response locally. So if you have a good and PET negative response locally, it's an argument to have a complete response locally. And also PET CT scan is a good modality to look for distant metastatic disease. We only use it when we really are in doubt. We don't use it on a regular basis.
So there is another question by Dr. Hemant Singh. If post CTRT there is still a disease T1N0, do you offer adjuvant chemotherapy to this patient?
No, we don't offer adjuvant chemotherapy. We at the moment we only offer chemotherapy in N+ disease. So patients who have remaining disease in the mesorectum.
I think Rudra, if you want to ask a question, we can unmute you, because there are 3 to 4 questions from your side. Can anyone unmute Dr. Rudra Acharya? Shushti?
Ma'am, participants can unmute themselves.
Yeah, I have done that.
He is there.
Yeah, Rudra, you just ask your question, because there are 3 to 4 questions from your side.
Yeah. So Albert, do you think that this salvage surgeries after recurrence, they're more extensive than the primary ones?
I don't think there is evidence that that salvage is more extensive. There is evidence that salvage surgery will lead to more definitive permanent colostomy. So more patients will undergo an abdominal perineal rectum amputation, APR. But I don't think that that there is more extensive surgery needed by means of exenteration or sacrectomy or anything like that. So in our practice, I don't think the surgery is more extensive, but there is more need for definitive colostomies.
Yeah. So that is why it is very important that the pool of patients you want to keep for wait and watch should be very meticulously being selected.
Yeah.
Out of the whether MRI assessment, pathology, the pathological behavior, then T stage, N stage, because putting everything into the same basket will lead to a lot of failures in local recurrence, and ultimately it will not help for what we are aiming for.
Yeah, I agree on that.
Thank you.
Madam's lecture is, Madam, are you there? Dr. Vinita, Madam?
There.
Yes, Madam. Can you please?
Okay, sure. I have unmuted myself
Hmm.
and sharing my screen. Just confirm to me, are you able to see my slides now?
Yes, Madam.
Okay. So after Dr. Albert's lecture, I just wanted to emphasize on few points that I think rectal cancer management, as we are discussing today, has now become more complex in last few decades because of introduction of new adjuvant therapies. And now because of these new adjuvant therapies, we have a new variable which we look forward to, and that is tumor response. I also wanted to emphasize that it is not wait and watch. It is watch and wait. It is akin to active surveillance or watchful waiting. And what we are trying to do is we are trying to adapt the treatment in response to the previous therapy. And I also wanted to say that as a radiation oncologist, I believe in watch and wait protocol. I agree that right now there is no level 1 evidence, but we have pooled analysis of large number of patients, which actually represents the real world scenario and not the controlled trial settings. And the reasonable follow-up is also available. And I find that this approach is oncologically safe because for the patients who have local regrowth of the tumor in the watch and wait protocol, majority of them are able to undergo a successful salvage surgery and they have similar survival, and a good proportion of patients are still able to avoid stoma and surgery.
Madam, slides are not changing. Can you please check
I
it?
stop share and start sharing again.
Or else Srushti can share your slides, then you can
Yeah,
speak.
I have already forwarded my slides to you. They are already
Yeah.
with.
Yeah, okay. I'll just share it.
Yeah, ma'am. The slides are changing now. Please do it.
Now it's changing now. It's changing now. Can you please start back with the 2 other slides? I mean, the previous slides. Yes, madam. Yes, please.
So I was just trying to say that I believe in watch and wait because we have a pooled analysis of large number of patients with a reasonable follow-up, and I find that it has an oncologically similar outcome as to the patients who undergo immediate surgery. And the other point that I wanted to emphasize is that in India, majority of the patients that we see are locally advanced. So I just have done a small calculation for all of you that suppose there are 100 patients with T3, T4, N plus disease, and they are treated with neoadjuvant therapy, and 25% of these patients have a clinical complete response and are put on watch and wait protocol. And in next 3 years, say 30% of them, they get local regrowth. Still 19 out of that 100 patients will still be colostomy free. And if we apply this approach of watch and wait and neoadjuvant therapy to T1, T2 tumors, a larger number of patients can still avoid surgery as well as stoma. So because of this protocol or this approach of watch and wait, I think pre-op CTRT or NACTRT has found a new indication, and it should also be considered in patients who have early disease. There are certain ways by which we can increase the number of complete responders so that more patients will be eligible to go for watch and wait protocol, which means the options are we wait longer as suggested by Dr. Albert through a lot of studies. The other approach which is suggested by Haber Gamma is that instead of giving 50.4 gray, these patients are given a higher dose of radiation therapy, and that is generally 54 gray in 30 fractions. We give more chemotherapy, which means after long course CTRT, we give them more chemotherapy before they are taken up for surgery. And we apply this approach of watch and wait and neoadjuvant therapy to early stage disease. When, as a radiation oncologist, I have to choose between short course radiation therapy versus long course radiation therapy for a patient who is likely to undergo watch and wait protocol, my answer is that data for watch and wait actually has come from long course CTRT. Short course is also known to produce pathological CR, but in smaller number of patients. If you're using short course RT, you have to certainly wait for a longer time and not evaluate response and consider them for surgery after 1 week. So my take home is that if you and your team want to pursue watch and wait, preferably use long course CTRT. And if you're using short course CTRT, then you have to wait for a longer time. Another very important point is that it is a teamwork. So the whole team should be aligned. The whole oncology team should adhere to the defined follow-up protocol to the core. And as emphasized by Dr. Albert, I think the follow-up of these patients have to be done by the surgical oncologist. Here, MRI is very crucial, but it is difficult to interpret. So you should follow this protocol only if you have a high resolution MRI available and an expert radiologist who can interpret these MRIs. Through literature, I think that CEA, serum CEA level is less talked about, but is also a simple and useful tool which can also be used to for follow-up of these patients. I also want to emphasize that watch and wait is not for everyone. We must choose our patients wisely. First of all, from the patient's perspective, I would say that the patient's compliance has to be checked. The patient should be able to understand what you're talking and how rigorous the follow-up will be required. There should also be an informed decision making that right now we do not have the level 1 evidence, but we have this large pool of data which is available. The patient and the family must also understand clearly that there is some amount of risk of local recurrence and the patient might need SOS salvage surgery. Watch and wait generally, I think, is not applied for upper rectal tumors. Tumors up to 7 to 8 centimeters from anal verge only are considered for watch and wait because these tumors are amenable for digital rectal examination. And preferably, it should be applied to patients who have T1, T2 tumors. It should be carefully applied for patients who have more locally advanced T3, T4 tumors or N plus tumors. And it should not be applied for patients who have mucinous or signet ring histology. So these are the only points from my side, Dr. Bhavana.
Vinita, that's an excellent analysis and a very nice view and points as a radiation oncologist. I fully agree with you with these points, but it's very important for us to understand rectal cancer is potentially curative. The point of this particular surgery doesn't arise if it is anything in the upper and mid, because the whole concept is to avoid a stoma. Surgery for the upper and mid rectum in the minimal access era without having a need for permanent colostomy is absolutely fine. We don't have a risk. Predominantly, this group applies in clinical real world scenario for low tumors where any surgery would be an abdominoperineal resection and permanent stoma, and that is when the patient and clinician actually explore, because upper and mid invariably post chemotherapy are going to be reservation unless there's like mucinous or signet cell, and then the issue doesn't arise because eventually patient is going to retain the sphincter. But it's very important that since there are no randomized controlled trial, the only evidence that predominantly is coming is from the Netherlands group and then the Haber-Gamma. But there are also two other large studies from Memorial Sloan Kettering and Nakawara group, where these two didn't replicate what the Haber-Gamma group showed. As I already enlisted, the Memorial Sloan Kettering showed that when there was a clinical CR by PET scan, endoluminal ultrasound, MRI, colonoscopy, and biopsy, when they really operated, more than 60% actually had a tumor, and node positivity was as high as 20%. And in Nakawara group, when they kept on watch and wait, as you mentioned, 60% recurrence happened and only 40% could be salvaged, which means we lost lives in remaining people. So we have 3 to 4 studies, only one shows, the other two not. And most often people think when you're in watch and wait, first symptoms, first time when it recurs, I'm going to operate. You will be surprised to know that that first time, in spite of the best follow-up, actually misses because there's not an upfront case. It's a post-chemotherapy, and not all can be salvaged. They end up with an exenteration, losing a bladder, or many other things. So that's why it is very, very important. And second thing is increasing the more radiation and other, the anti-rectal syndrome will be so high, then the quality actually outweigh actually preserving there. It's very important to understand that, that is one of the reason we have 5040 threshold, that we may end up with increasing and the quality of life and lifelong being a cripple on that sometime is bad than having a good stoma. We always say that a bad sphincter, badly performed sphincter preservation is worse than a well-performed, end stoma. Third issue, what you brought out is most of the evidence of pathological CR and wait and watch is in long course. Not so. If you see the Rapido trial, the clinical trial arm was TNT 5 fraction shot, which was a Swedish protocol. And they already showed that the pathological CR rate was double compared to a conventional chemotherapy. So we already know that short course 5 dose doesn't mean inferior PCR. As long as you wait up to 12 weeks, the PCR rates are double. So there's a lot of mixed evidence. In science, there is no absolute yes or no. It is very important as a wise man. Patient, you yourself and MDT chooses the right patient. So all patient didn't have to end up with a surgery. There definitely is room for patient where we can go for wait and watch. And all patient doesn't go for wait and watch. It needs to be there. And that is where the thin line of balance is. And I think more clinical trials will throw more light, but TNT is extremely encouraging if things mature.
So Dr. Somsekhar, many thanks for your valuable inputs. And I think you were almost replicating whatever I said. I also emphasize that it is not that short course cannot be used, but one has to be conscientious that if you're using short course, then one certainly needs to wait for a longer time period.
As far as Rapido trial, 12 weeks we wait.
As far as dose escalation is concerned, I would like to say that this dose escalation is not up to 60 gray, where the problems of sphincter and the LAR syndromes, they increase. It is only a mild increase in the dose. From 50.4, we are going only up to 54, which is unlikely to produce a lot of symptoms. I have a question for you. Probably you also asked Albert the same question, that why do you think is there such a big difference in the outcomes of the series from Mexico versus the MSKCC series?
Yeah, because the main reason is none of them are randomized trials. So the moment you don't have a RCT, there is a high bias. I will tell you, not many people know that Rapido trial is not done by surgeons. It is done by medical oncologists to push more chemo. So if the same Rapido trial is done by a colorectal surgeon, take my word, the results and the end game and then the primary outcome and secondary would be different. So it is basically personal biases which creep in until a randomized controlled trial done, and then selective group of patients in selected institution. That's one of the reason which comes. But out of 4 meta-analysis, 3 of them actually showed that even if at the first site of recurrence you salvage them, not everybody cannot be salvaged. And the salvage surgery is never simple APR, most of them end up. So the main answer lies in doing a randomized control which is unbiased. That would probably answer everything.
So I think the surgeons have to be ready for such a trial. I'm sure radiation and medical oncologists are game for it. And I'm sure such a trial would...
surgeons were ready. Otherwise, these trials wouldn't have been done because, currently in rectal cancer, the level of evidence is surgery for all. Without surgery, there is no cure in rectal as of today. So any trial which are done, always surgeons are on the board. Otherwise, this surgery wouldn't do because everybody is on the board.
Let's hear from Albert. What are his comments on this discussion?
Yeah, it's difficult to add anything. I mean, I completely agree with Dr. Somsekhar and also with Dr. Gul from as a radiation oncologist. It's very hard to bring anything extra in the discussion. I mean, it's completely. You are completely right. You also have to look at the part of the world where the trial has been done, looking at generalizability, looking at patient population, looking at funding. I mean, your points are absolutely correct in that looking at it starts with patient selection, and if you select different types of patients, if you compare different types of patients in different types of trials, you will done by different types of healthcare professionals, you will get different results. I'm sure about that. So very nice. It's a very nice discussion.
Yeah. Over to you, Dr. Bhavana.
Yes, we have a question in chat box. I think you already answered, madam. It is by Dr. Deepak Damodharan. Is it possible to have a wait and watch for short course radiotherapy? He asked, I think, madam, you already answered, but the question for Dr. Albert.
Yeah, definitely. That is definitely possible. And the colleague already has alluded to that. Um, what we normally did was 5x5 short course, and 1 week later we operated on that patient. But now, if you want to get a complete response, and it is possible, then you have to, of course, wait longer and wait 8, 10 to 12 weeks. But with a 5x5 approach, you definitely get complete responses as well. So a watch and wait protocol is possible in this approach.
There is another question by Dr. Mahavir. If the Dr. Mahavir is there, can you please unmute him? He asked that as many of our patients are reluctant for permanent stoma in future, so can we start NSCTRT or this for this patient, and can we put him on these patients on a wait and watch and administer aggressive neourgent chemoradiation? Shushti, can you unmute him so he can also ask question directly?
Hello.
Yes,
Hello.
Dr. Bhavana, yes.
Yes, my question is some patients are reluctant from the start of the treatment protocol for a permanent stoma. So we are subjecting them for NSCT-RT. So can we go for aggressive NSCT-RT in a small lower rectal cancers on posterior wall, and then we can put them on wait and watch. So from start of the therapy, can it be more aggressive, more intense chemo and radiation therapy?
Yes, but you will also have more toxicity then. The problem then is if you do more aggressive treatment, if you combine oxaliplatin with radiotherapy, you will definitely have more patients on grade 3 toxicity, more diarrhea, more side effects. But if you want to avoid a permanent colostomy, that aggressive treatment is sometimes justified, but you will have the price of toxicity.
Oh, thank you.
Okay, we have one senior oncosurgeon, Dr. Subramanyeshwar Rao sir. Can somebody unmute him and comment about this entire session if sir is available there? After that, Dr. Albert, I have got two questions. Hello.
Please.
Yeah, just want to ask, how is your follow-up protocol? How frequently you follow these patients? So on a wait and watch, monthly, 2 monthly, 3 monthly. Somebody says you do it for the 1 monthly for 9 months, and then after 3 monthly.
No.
And the second thing is this option should only be given to the patient, those who have come to the surgeon for the first time, and the same surgeon is going to follow him. So what is your take on that? You do same thing in your routine practice, or somebody else has not seen and the patient comes post CTRT and you offer a wait and watch policy to them?
Yeah, very important question. We do 3 months follow-up during 2 years. So every 3 months, 3 to 4 months, every 3 months, we do investigation during 2 years. And after 2 years, we do it 6 monthly. So half yearly for 5 years, and then yearly after. I do flexible endoscopy in the outpatient clinic, and MRI is performed most of the times here in hospital. If a patient has a complete response after treatment, I sometimes get referral from all over the country to follow that patient up, and I'm happy to do that. So, but then it is important that I see the patient back on the regular follow-up scheme. So I really would argue that the same surgeon is or the same doctor is following up the patient in that trajectory.
And MRI is also every 3 monthly, or it is just your flexible endoscopy will do 3 monthly?
No, we also do MRI 3 or 4 times per year. So it is quite intense in the beginning. Yes, and we discussed that at MDT. And then after 2 years, we do it half yearly MRIs.
Okay, and I mean, it is seen in wait and watch policy that majority of local recurrence occur intraluminal. So, how is your experience? I mean, in your studies, these those who are having a local recurrence, it is intraluminal or in the mesorectal areas?
Sorry, what is the question?
Majority of recurrence occurs intraluminal.
Yeah.
So, so this treatment is offered. Wait and watch treatment is offered only because there is an intraluminal recurrence majority of time. So, what is your experience with that? It is in your patients or it is same? The recurrence patient is having intraluminal recurrence or extraluminal recurrence?
Yeah, most of the recurrences are intraluminal.
Okay.
So, yeah, that is sometimes a point of discussion, but most of the times you see something happening with the scar, you see an ulcer, you see tumor growth, you feel something. So a submucosal recurrence, I haven't seen that, but you can have a recurrence in the lymph node, of course. And that's why we do the MRI.
Okay. Dr. Shubham has asked,
Yeah.
your take on intralectal ultrasonography 3 monthly instead of MRI for low-income group countries and MRI, just like in India. That will you? I mean, are you comfortable in doing intralectal ultrasonography as compared to MRI?
Yes, I think you can do that. But then you should train yourself to be a very good ultrasonographist. And there is some evidence to show that you can pick up local regrowth also with ultrasound, but in our hospital it's not possible because it's not the same doctor who's doing the ultrasound. There is not much experience with that, but it has been shown from a group from Argentina, showing that it is possible following the patients with endorectal ultrasound.
Dr. Rohit Mishra has asked question that performing surgery, it is easy after short course radiotherapy or it is easier after long course radiotherapy for rectal cancer after wait and watch protocol?
It depends on the interval. I'm not so sure that that I agree with it with this fact. You can also have a very difficult case after short course radiotherapy with a long interval. So I don't think that that this statement is true all the time.
It depends upon the case, how a patient comes to you, the kind of recurrence you are the patient is having.
For the recurrence?
No, I mean, I think it depends upon the type of recurrence the patient is having. The surgery will depend on that actually.
Definitely, that is a very good point. Yeah.
I think there are no more questions. Is there any comment from expert commenters, any of these commenters? Or anybody who wants to speak anything about, or anybody wants to ask question to Dr. Albert? It was a really wonderful session by you.
Yeah, thank you.
I enjoyed it thoroughly. I think, I don't know if people will like this topic or not, but it was
I enjoyed it.
Yeah, I enjoyed
Hello,
it.
can you hear me?
Yes, madam.
Yes.
Dr. Shabnam this side. I just wanted to know, since we know that majority of these regrowths will be intraluminal, what is your take on the intraluminal brachytherapy in addition to the radiation therapy that we give for these patients to reduce the regrowth in the watch and wait policy?
Yeah, that is a very good point. The brachy or contact radiotherapy to increase the radiotherapy dose is used in Europe in a few centers. There's one center in the UK, one center in Amsterdam, one center in France. We don't have experience with that approach in Belgium, but there is some data showing that you can increase complete response and that you can also treat local regrowth with it. But then you can give 50 or 60 gray, and then sometimes you will really have an ulcer, or you have bleeding, or patients really become symptomatic when you do that. But there is some data supporting the use of endorectal radiotherapy, definitely.
Thank you, sir.
Dr. Somsekhar bhai, Dr. Ashish, Dr. Vinita madam, is there any comment from your side? Shall we? I think there is one question in chat box. Okay, there is a question by Dr. Ajay Vani. We can unmute him also. Is there any, if there is a tumor location in rectal cancer, whether it's anterior wall, lateral, posterior wall, does it have any significant difference in overall survival of the same state disease?
Yeah, anterior tumors do worse. So there is data from the different rectal cancer trials showing that anteriorly located low rectal tumors in male patients do worse than posteriorly located tumors.
So you mean to say that anterior rectal tumors have got some different survival as compared to the rest of the other parts?
Probably.
Okay. Vinita madam, do you have any question by now? Or?
I don't have any question. Just one thought which came to my mind. Albert, any experience of using intraoperative radiation therapy for recurrent rectal cancers? You know, not in watch and wait protocol. Generally, I'm asking.
Yeah, not intraluminal, but intraoperative.
Correct. Okay.
Yeah.
You have an experience with intraoperative radiotherapy.
Yeah.
Okay. You routinely practice that.
We only do that to anticipate R1 resections.
Correct. Okay. Just my question was, if, is there any, there is a, thing that the patient is put on a wait and watch therapy and then there is a recurrence. Patient lose a chance of TME and patient has to go for some radical surgery like APR and permanent stoma. How is your experience with your patients, all of your patients?
Sorry, I didn't get it.
Any of your patient who has got a recurrence and you have to end up in doing a radical surgery, which if you would have done previously, then it would have been a TME or some, the patient should avoid a radical surgery. So is there any experience with your patient who recurred and required surgery, or you intensely follow patients very closely and pick up the recurrence as soon as it occurs?
Yes, of course. Of course, but what do you mean? That we operate on that patient?
You operate on the patients and you feel that he required more radical surgery as compared to if you would have operated earlier?
No, that's not the point. No.
That's not a point, because majority of things it has been written that if a patient has got a recurrence, patient lose a chance of TME and colorectal anastomosis or the rectal anastomosis, and he or she has to go for permanent stoma. So if
no, that's not the case.
No, it hasn't happened to you. There is no experience with that. Okay.
No.
Okay. So it means your follow-up is extensively and
yeah.
Okay. Dr. Hemant Singh again asked the question. We can unmute him. When there is a complete response, why would you give an adjuvant chemotherapy? We can unmute Dr. Hemant Singh if you want to ask the question.
Yes, ma'am. Sir, just wanted to know, means like for what YPT would you give adjuvant chemotherapy? Would it be YPT2, YPT3, or you're just looking for a disease in the mesorectum? I mean, what?
Yeah, we look, as I told you, we only look for disease in the mesorectum, but then you can have an individual discussion with the patient. But we normally don't look at the YPT stage.
Okay, so do you be looking only for N status? Okay.
Yeah, and it's not for me up to decide. It's our medical oncologist who discussed that with the patient.
Okay, sir. Thanks a lot, sir. Thank you.
I think it is excellent, Bhavana. We must let Professor Albert go. Otherwise, we have to keep him for lunch, dinner, and breakfast.
Yeah.
I think I thought it will be over soon, but I think we took almost 1.5 hours. Thank you so much, Dr. Albert. We reached up
No,
to
thank you.
155 participants. You asked me, is there any participant? I said there are many participants.
Yeah, very good.
So we reached up to 155. There was some internet connection issues, so few people left, but still we enjoyed a lot. People asked a lot of questions.
Very nice.
Hope to see you soon again. Thank you.
Yes, I hope to see you soon. We can stay in contact and exchange some ideas, and hope to see you in the future.
Few people ask about your email ID. I will share your email ID with them if they ask me personally.
Great.
Thank you, sir. Thank you so much.
Thank you. Thank you. Have a good night.
Good night.
Thanks for having me. Good night.
Thank you very much, Dr. Vinita, madam. Thank you.
Thank you. My pleasure and honor. Thank you.
Thank you. Nice to meet you. Nice to see you all.
Thank you, sir. Thank you so much.
Thank you,
Bye-bye.
Dr. Albert, Dr. Bhavana, Dr. Vinita,
Bye-bye.
Dr. Ashish Joshi, everyone.
Thank you,
Thank you
Shushti
so
and
much.
Dr. Ankur. Thank you.
Dr. Somsekhar also. Thank you so much.
Thank you, Shushti and Ankur. You won the art.